the diagnosis osteoporosis is literally a big fancy term for low bone mineral density. So our skeleton is obviously made up of bones, and our bones are made up of minerals like calcium and hydroxyapatite and things like that, big long words that form our skeletal structure. And if our bone decreases its mineralization, it gets less dense and more prone to fractures. So if people have low bone density, they are at risk of something called a fragility fracture, which is really where I come in, right? So as a orthopedic surgeon, if you break your bone, unfortunately, that's how I often meet people. And a fragility fracture is not a term that applies to people in terms of, oh, you have a fracture because you as a person are fragile. It's because your bones are fragile, right? It's because your bone mineral density is below what it should be. And the way I like to describe it is, if I fall down, if I slip on the ice and fall down and I brace my fall with my wrist, I mean, if I have good bones, 90% of the time, I'm not going to break anything. Even with good bones, obviously, sometimes you break stuff, but like if you have really poor bones, one fall can lead to really devastating consequences like a broken hip or even a broken spine. I see a lot of broken arms in my practice. I've treated a lot of broken pelvises. So the these are bones that shouldn't break from just falling from standing. I've seen bones that broke just from people falling from a chair. Like that's a very low energy mechanism to break a bone. So that means that the bones were fragile to begin with. So the thought here, the whole concept here is trying to avoid the bones becoming fragile, and that way you're possibly preventing things like broken hips, broken spine, right? I mean, a broken hip is really devastating, and it can really take somebody from being independent to needing to lose independence, and that's really a scary thing for a lot of people. So if we can build up our bones, we can maintain our independence longer. Fragility fractures are a huge cost to not only the system, but also to our patients, right? The surgery, immobility, and loss of independence is what I'm trying to prevent with this talk and maybe teaching people to prevent fragility fractures. This is just the data from 2021, the On the Bone talk, where they talk about fragility fractures and what is the percentage of fragility fractures? Actually, over 50% of fragility fractures are in the hip. So the reason why that's so important is because if you break your hip, that completely takes away your ability to walk, and you do need surgery for that. So that, as you can imagine, can be devastating to people. So the more we can prevent this, the more we can prevent these fractures, the more we can preserve our function and our overall community health, really. And why is this so hard to treat, right? So this is why the Own the Bone program exists at the AOA. It's a national organization, and it's identified fragility fractures as really an area of need, an undertreated portion of the population. And it's because your primary care provider is addressing lots of other stuff. They're often thinking about your heart, your lungs. If they're managing your chronic diseases, they're not necessarily thinking about your bones. And then you become osteoporotic and you don't even know it. And then a fracture occurs and you show up in my office and I fix your fracture, you recover from it, but then the osteoporosis is never treated. If you try to get into the endocrinologist, it can be really hard because they're very busy treating all the other things. The question of who is responsible for fragility fractures and managing fragility fractures is why I am here talking to you today. That's why an orthopedic surgeon is talking to you about this stuff, not an endocrinologist, not a primary care provider. Like, we all have to do it as a team. What I would propose is that we're all responsible. Patients are responsible. Orthopedic surgeons are responsible. Primary care providers are responsible. We need and our endocrinologist colleagues to help us out. We all need to be thinking about this because fragility fractures they can't. They're too devastating. We have to avoid them with any and all tools that we have. So, as the orthopedic surgeon, what I try to do is every single fracture that I deem a fragility fracture in my clinic, I will try to talk to them about their bone health, get a bone density study, and ask them how are they treating their bone health, because I need to start that conversation and move the process forward and get these untreated, a really undertreated disease into the forefront, right? So, what causes low bone density, right? This is another sort of common question. And the answer is very, very many things can cause low bone density. This is another reason why it becomes a multi-specialty issue. There's things like endocrine causes, nutritional causes, uh, there's so many different causes where I, as an orthopedic surgeon, I can't be necessarily, I'm not going to be managing your, hyperparathyroidism or your hormonal imbalance because I'm going to be focused on surgery, or I'm not going to be helping with your seizure disorders or drugs, but these can cause low bone density. So being aware of this and trying to talk to everybody about it, right? It should be brought up at your visit, definitely at your orthopedic surgeon visit, definitely at your primary care visit. Bring it up if you have another subspecialist you go see. Say, hey, like, have you thought about my bone health? And if not, do you know of anything that would cause low bone health or what can be done for it? Um, so, I mean, this is an exhaustive list of so many things that can cause low bone density, and that's what I'm going to talk. I'm going to sort of dive into the ones that I think just anybody can really address on a day-to-day basis to start. So, nutritional causes, right? I think diet comes up a lot. Diet is another thing that is probably under discussed in the doctor's office, because what we eat and put into our bodies really becomes who we are. That you are what we eat, you are what you eat sort of phrase is, um, it's more and more true today. But I think that from a bone perspective, and for bone perspective, as residents of Wisconsin, it becomes even more important to focus on getting vitamin D and calcium in your diet. So vitamin D is actually comes from the sun, and as we all know, Wisconsin has, to my wife's chagrin, Wisconsin has 7 months of winter, essentially. We just had a huge snowstorm in November, and my wife's from Ohio, and she's never seen snow in November before. So, but the point being, when there's not as much sun, you don't get as much vitamin D. So you can't get it from the sun. You have to get it from other areas. And honestly, I think vitamin D supplementation, especially in the wintertime, should really be done for the entire Wisconsin population. There are studies out there that show that 3/4 of Wisconsin's population is vitamin D deficient. Now, why is that important for bones? Because vitamin D helps build and promote bone mineralization. Like we talked about, what is bone density? It's bone mineralization. The more minerals you have in your bone, the more dense it will be, the better your bone health. So, calcium and vitamin D are the two big ones that are easy to sort of have some lifestyle changes that you can maximize your calcium, maximize your vitamin D. And in this way, you're trying to prevent demineralization. So it can be a cause of low bone density. So avoiding these deficiencies is really important. Now, the concept on the last line there, where it says vitamin D and calcium are threshold nutrients, is also important. It's not like, oh, I have to maximize my calcium and vitamin D. Once you take enough, taking more is not additionally beneficial. It's not like the more vitamin D you take, the more dense your bones are going to be. You reach a threshold and then you have what you need. So the recommendations for amount of vitamin D are wide and variable, right? These are different societies that recommend different standard amounts of vitamin D for people. I think the way vitamin D is measured is often in international units. And I think if you're taking 1,000 international units a day in Wisconsin, especially during the winter, I think you're covered from a vitamin D standpoint. That's my medical opinion. Obviously, the Endocrine Society would advocate for 2,000 or 1,500 to 2,000. And I don't think they're wrong. I'm not an endocrinologist. They come from where they're coming from. So I think that vitamin D, I guess, I mean, in my clinic, down in Dayton, Ohio, in the pediatric clinic, we would give vitamin D to our pediatric fracture patients. And pediatric, obviously kids, their their bones are really strong. They're the strongest bones around, but we're giving them. So vitamin D is good for bone health, whether you're 5 years old or 105 years old. So it's a making sure you reach that threshold is so important, and it's underutilized in Wisconsin specifically. 70 up to 70% of Wisconsinites are vitamin D deficient, which means that we probably have poor bone health compared to some of our other state peers. From a calcium standpoint, just look at the calcium column that's not outlined in red. They talk about 1,000 milligrams, 1,200 milligrams. I am going to tell you, I advocate more for calcium through the diet than I would for calcium supplementation. Calcium supplementation can have issues with kidneys and heart. That is, I guess, outside my scope of practice as an orthopedic surgeon. Obviously, I am not somebody who would manage kidney stones or heart disease if you have a lot of calcifications in your heart. And I don't want to push people towards needing those things. So sometimes calcium supplementation can actually put you at increased risk of that. So what I would tell you is try to get the amount of calcium that you need through these dietary sources. I mean, it's like what I preach in my clinic is what I call the healthy lifestyle. I'm not trying to get you on a diet that you're not going to be able to maintain. And we're not going to do fad diets in my clinic. We're not going to do, fad workouts. I'd rather get you on a routine that's sustainable, on a diet and a workout regimen that's sustainable, that is good for your health, that you enjoy doing, and that will overall maximize your independence and your bone health. Because if I can sell one thing to you guys today is that the stronger your bones are, the longer you will maintain your independence. Because if you can avoid that hip fracture, you're gonna be able to mobilize so much better. So if that's not a argument to try to maximize calcium in your diet, maybe do some more broccoli, add some kale, work in some yogurt. These are things that you can buy cheap at the store. You start eating a little bit more of them, and it can help in the long run. If you only do it for a few weeks, it's not sustainable. Healthy lifestyle. This isn't a fad. Try to apply it and use it longitudinally. It's hard, but I think that's part of what is so important and so hard in today's world is to try to do things that are sustainable, that last. So this is just a short list. There's plenty of the other thing I tell people in my clinic is that in today's world, there's so many healthy options at the grocery store. You can go to the grocery store and buy like high protein chips, right? I mean, you can buy high protein mac and cheese. Like these are things that obviously weren't available, at least when I was growing up, but I guess my point is like if there's ways to eat the things you like, but try to maximize protein and maximize calcium in with different additives or different recipes, and again, trying to minimize those fractures and increase longevity here. So, what else should you eat? There's actually been some recent studies that have shown that probiotics, specifically in postmenopausal women, actually decrease bone loss. I think that the diet and gut is becoming more and more on the forefront of not only medicine but also sort of alternative medicines, alternative medications, and alternative sort of providers are really sort of jumping on this ability to have a really healthy gut because your bowels and your gut have bacteria that are symbiotic. They are your friends. And if you have good bacteria, you're healthier. And if you have bad bacteria, you're more unhealthy. And again, I'm an orthopedic surgeon. This isn't my specialty, but advocate that this is real science. And there, from my standpoint, there are real studies out there that have shown that if you have probiotics on a daily basis compared to a placebo, so literally people have yogurt, and then they have placebo yogurt that has no probiotics, and they compare these two groups. The people who had the real yogurt had better bones 6 years out, right? I mean, these are long time studies. So like this stuff matters, right? So, trying to not only increase your calcium intake, but think about having high protein diet, minimal sugars, these really high carb density sugars that are just throughout the American diet really promote poor gut health, and poor gut health can lead to poor bone health too. So, um, probiotics are another sort of tool I would use personally in order to maximize not only my bone health but my overall health. Again, it goes back to that healthy lifestyle. We're trying to prevent fractures and maximize our independence. Other causes of osteoporosis include pharmacologic, and um, the medications we take can lower our bone density. The drugs that we take can lower our bone density. So if you're taking alcohol or tobacco, both of those cause very low bone mineral density, partially because they cause poor microbiomes and poor gut health, and you have malabsorption disorders with these. And if you don't have the vitamins and minerals you need, your bones are one of the first things to go. So, trying to cut back on the alcohol, cut back on the tobacco, maximize your diet. And then if you do have a medication, asking about the side effects. If you're on multiple medications that have a side effect of lowering bone density, it might be worth talking to the physician who's prescribing that medication and say, hey, I'm worried about my bone density. I'm worried about possible fragility fracture. These are becoming more and more common, and we're it's sort of almost this silent the bone is the silent organ, right? It won't hurt if you have low bone density. You won't say, oh, my back hurts, or my legs hurt. They're just fragile, and then once you fall, obviously if you break it, it's a disaster. So it's sort of this silent uh, disease that can sort of spring up on you when you're trying to, well-meaning people, right? They're just trying to go to the doctor, take the medications prescribed to them, and live healthy lives. But thinking about your bone health is super important. And I mean, highlighting the side effects and the danger of using steroids a lot is something I want to talk about, because, I mean, geez, my brother uses steroids a lot because he has really bad allergies. And I'm like, you got to get off the steroids because if there's so many bad side effects. And as a bone doctor, the one I'm most concerned about is steroids really, really lower your bone density. These aren't steroids they're not anabolic steroids. These are steroids that people give for if you have, a flare of, they're anti-inflammatory. So if you have a lot of pain, sometimes people use steroids. If you have a lot of allergy issues, or if you have a lot of issues with chronic lung disease, you can be put on steroids. And if you're on steroids for long periods of time, or frequently, even if for short periods of time, very frequently, it can lower your bone mineral density. So when used correctly, they're appropriate, but you have to try to avoid them at all costs, because they lead to low bone density, and it will decrease your longevity, decrease your independence if you have that fragility fracture, if the devastating outcome occurs. It's too risky to have low bone density, right? I mean, anything you can do to prevent it makes a lot of sense to me. And I'm biased. I'm an orthopedic surgeon. I'm a bone guy, but it's sort of, this is my soapbox, right? So the other component, so I mean, diet, right along with diet, after healthy lifestyle, it's exercise, right? So there's actually a law in orthopedics that every orthopedic surgeon is taught. It's called Wolff's Law. Wolff's Law means that if you don't use it, you lose it. What is that? So Wolff's Law is a mathematical law that shows that it predicts the progression of loss of bone during immobility. Okay, every single orthopedic surgeon is taught this. So what that means is we've known about immobilization causing low bone density as orthopedic surgeons for decades. You know, it's what we've always. Immobilization is part of our practice when we're treating fractures, and we know that it causes low bone density. It barrels down to if you don't load your bones, those bones, your body won't realize that you need the bones anymore. So you become it stops building the bones up. If you load your bones frequently, regularly, your body realizes it. There are mechanical sensors in your bone that you can't feel, you can't control. The mechanical sensors sense you loading your bone and lay down more bone. This is how the body works. It's biology. You can't change it. It's not something you can think out, right? It happens no matter what. So in order to get those sensors to activate, you have to move. You have to do weight-bearing exercises. And the AOA recommends weight-bearing exercises 3 to 4 days per week for 30 to 40 minutes. And they recommend resistance exercises 2 to 3 days per week. So this is not a 15 minutes once a week thing. This is a commitment to a healthy lifestyle. And again, my advocate, as your advocate, I would say try to do something that is sustainable. Find something you like, right? I mean, there's so many different options out there nowadays to stay active. And it's just everybody's got a different flavor, right? And I would say don't jump from flavor to flavor. Find one you like and just thrive in it. That would be my recommendation. But if you're somebody, if you stay active, jumping from flavor to flavor, that's fine with me too. I mean, the more you move, the more you activate those sensors in the bone, the more bone you will have. If you don't activate those sensors in the bone, you will not lay down any more bone and your bones will become soft and fragile. Again, fragile leads to fractures. Fractures lead to loss of independence. So my pitch to you is use your diet, use exercises in order to maximize your bone health. The old one, I think the maximum bone health you have, your maximum bone density is when you're about between 27 and 32 years old. Okay. That's younger than I am. Okay. I've already passed my maximum bone density. Okay. I'm on the downward trend here. The best I can do is fight that downward trend with healthy lifestyle, healthy diet, weight bearing exercises 3 to 4 days per week for 30 to 40 minutes. You know, that for a male, I don't have menopause that's against me, right? So the downward trend is actually a little bit faster in men than it is in women, except once women go through menopause, women's downward trend accelerates to the point where women have more osteoporosis than men do. So if you're above the age of 27 to 32, you've already passed your maximum bone density. You've been downtrending for however long it's been. The only way to slow it is to do these healthy lifestyle changes, weight bearing exercises, vitamin D supplementation. That if you're saying what supplement do you recommend, Dr. Henningsen, I would say vitamin D, particularly in the winter. And then really maximizing your diet with probiotics and high calcium foods, high vitamin and mineral foods. These are ways to maximize your bone health. The pharmacologic treatment and next steps. So this is where it becomes outside the realm of orthopedic surgery because I spend my time in the operating room fixing fractures and managing surgical issues. So with regards to medications, once you have osteoporosis, there are medications that have been shown to reduce fracture risks and treat osteoporosis. These medications have positives and negatives, and everything has positives and negatives. There's risks, there's benefits, there's pros, there's cons. And it really is a patient-dependent determination of whether you need to be on that medication or not. And I think talking to your PCP about it, talking to your orthopedic surgeon about it, there are a couple different bone health clinics in the area. There's one through SSM and there's one through UW that I'm aware of. These are people who can sort of help you with that decision making if you need to be on a medication or not. I can't recommend a medication. I don't, but if you're to that point already, if the downward slope has already passed a certain threshold, you might need the medication, and figuring out whether you need that medication is important. There are imaging tests like the DEXA bone mineral density scan, and I order this scan out of my clinic very frequently to see what my patient's bone health is. And once they have a diagnosis of osteoporosis, it's really important to talk to them about the diet, about the immobilization, exercise, but also getting them to somebody who can talk to them about those medications as well. So that's sort of my pitch on bone health. It's sort of one of my soapboxes. It's one of my passions, but it's not what I do on a daily basis. I'm a surgeon. I fix broken bones. I replace arthritic hips and knees. Um, but I'm happy to answer any questions, and I hope you learned something today, and maybe start doing adjust your diet and exercise to maximize your health.
Terrific. If you want to go to the chat, Dr. Henningsen, you could probably start there. There's a few questions in there.
Sure, I'll try. Maybe I'll go back to this, and then okay, let's see here. The chat. All right, let's see what they got. I wondered about the OsteoStrong company and their advertising saying they provide evidence-based musculoskeletal strengthening. Does it work for older women to build bone? What I would say is, um, I went to the OsteoStrong website today. I don't know anything about their specifics. I would say that there is evidence-based studies that show that, and there's even a law that states that bone responds to weight-bearing exercises. The OsteoStrong company, if they're selling you, 15 minutes once a week, there's no evidence that supports that. But there is evidence to support that weight-bearing exercises, there are mechanical receptors in your bone that respond to weight bearing, whether you're 5 or 105, whether you can't turn them on with your brain. The only way to turn on those mechanical receptors is by weight bearing. Um, so anything that gets you weight bearing for 30 to 40 minutes a day, 3 to 4 times per week, that's sustainable would be what I recommend. There's 1,000 different flavors. If OsteoStrong is one of those flavors, and it works for individual patient, I'm all for it. But I'm also not going to say that it's going to work for everybody. And it's so important to realize that you have to commit, right? It's not just once a week. It's not just, oh, I do it every February, you got to commit to it and make it a sustainable lifestyle choice. Um, What type of probiotics does Dr. Henningsen recommend? The probiotics that I take are I take kombucha, and I use yogurt. So I do yogurt in the morning and kombucha on the weekends. These tend to be just and anything. I don't have a specific pill necessarily. I know you can buy them in pill form as well. My personal preference is to try to get through my diet as much as I can to minimize the amount of pills I have to take. That doesn't necessarily work for everybody. Not everybody likes yogurt. My wife doesn't like kombucha, so I guess my recommendation would be find something that works for you. And it might take a couple tries. Don't get discouraged. Dr. Henningsen said kombucha is the best way, and I don't like kombucha, that means there's no way to do it. Definitely a way to do it, you just got to find it. I might not even have all the answers there because as an orthopedic surgeon, it's not like I recommend or have a probiotic discussion on a daily basis, but I do know that there's data to support, particularly in postmenopausal women, I know that's a weirdly specific population, but the data would support that probiotics, specifically in postmenopausal women, can slow the decline of bone density. Because, like I said, once you're 31, it's hard to build it back up, but you're trying to slow the decline. If you've had a hip replacement, are you still susceptible to hip fractures? Yes. I treat periprosthetic hip fractures. I have treated them a lot. You can break your hip around a hip replacement. Um, and those tend to be more complex actually than a normal hip fracture. Um, the hip replacement is metal that is your bone has grown into that metal in a hip replacement. So you're not walking only on metal. You're still walking on your bone. Um, and your thigh is still mostly bone, and you can break that bone, unfortunately. So yes, bone health and hip fractures can happen even if you've had a hip replacement. How much calcium should I have a day? I had a table here. Um, so different recommendations from different societies, but pretty much 1,000 to 1,200 milligrams tends to be the recommended dose of calcium per day. And my recommendation is to get it through your diet as much as you can. In Wisconsin, we eat a lot of cheese. Look at that. 1 ounce of cheese is 100 to 200 milligrams of calcium. You know, I mean, I don't get away eating 1 ounce of cheese a day. I'll say that. I eat a little bit more than that. Our diet cola is detrimental to bone health. I would say, um, specifically, I'm not aware of diet cola specifically being detrimental to bone health. Um, from my standpoint, um, I would encourage, I don't think there's a drink per se that will be what I recommend to maximize your bone health. It's really trying to maximize your protein, maximize your calcium, supplement your vitamin D, and try to have as healthy of a diet as possible, whatever works for you. Beyond that, the specifics of the detriments of diet colas are probably beyond the scope of what I can talk about. Um, Anybody else want to jump in? I'm just rolling through the chat here. If someone wants to jump in, I can keep going. But um, how much weight do you need to lift to build bones? I would say you can build bones with body weight alone. You don't need to have weights. Um, I think that, I mean, there's weight bearing in my mind is enough. Walking is great for your bones. If you're saying resistance exercises doesn't mean picking up a dumbbell. You can do resistance exercises by, doing leg lifts, doing squats, doing planks, arm circles. These are all resistance type exercises that you don't even have. You don't need a home gym to do this stuff. You know, I don't have a home gym. I do almost all of my workouts are body weight workouts. So it's not you need to lift this much weight to build your bones. It's find something that you like to do that will be sustainable because that's what you'll stick to. If I say, oh, if anybody tells you it's only this, they're just trying to sell it to you, right? There's no one way to do it. Um, Vitamin D, should it be vitamin D3 taken with K2? I'm not gonna know what K2 is. I think vitamin D3 is enough. If you're thinking about more specifics vitamin D, or you need higher doses of vitamin D, or something because vitamin D can get pretty complex, and you can get into activated vitamin D and inactive vitamin D and things like that. That's probably a discussion with either like an endocrinologist or somebody who knows a little bit more about it. Honestly, I know the vitamin D cycle, but I've never specifically, written for prescription strength vitamin D for anybody. Um, so I think that if you're having if you have a genetic vitamin D deficiency or something like that, those are things that need different vitamin D supplementation. I'm more talking to the general population for vitamin D supplementation. Anything beyond that's probably outside my scope. Um, so exercises that you would not recommend. Um, I guess exercise, if you have osteoporosis, I would not recommend you put yourself at risk of falling. I would not recommend you put yourself at risk of any type of high energy injury. Like, I wouldn't necessarily recommend skiing for somebody who has osteoporosis. I would rather that person do more weight bearing exercises to load their bones in a safe environment. I mean, it's trying to avoid fragility fractures because once you have osteoporosis, you are at risk of fragility fractures. So putting yourself in a position where even somebody who doesn't have osteoporosis would get fractured would probably be unwise. Um, do osteoporosis medications improve bone density scores or just stop the score from getting worse? That's a great question. And there are a couple osteoporosis medications that are something we call anabolic. Um, where they're truly building bone. There's only a couple of them. The one that comes to mind is a synthetic parathyroid parathyroid hormone. The synthetic parathyroid hormone is what it's called. Now that's not. I'm intentionally not using brand names, but that would be one that could possibly be more anabolic. Um, but I wouldn't necessarily, once you have the diagnosis of osteoporosis or even osteopenia from a DEXA scan, it's not like cholesterol, we're trying to hit a number. Um, what I would say is use it as sort of a warning sign to maybe change your lifestyle or get on a medication. Because most of the osteoporosis medications are what you say, they stop you from getting worse. They don't build bone, but they halt the breakdown of bone, which is still good medication, right? If you everything's in equilibrium. If you're building at a certain rate and you're breaking down at a certain rate, um, if you stop the breakdown, you will continue to build. Everybody's building bone at a certain amount. It's really just trying to make sure you're building more than you're breaking down, or at the very least, minimizing that imbalance of breakdown versus build. So again, a little bit outside the scope of my practice, but because I'm not an endocrinologist, but ask your mother about, not your mother, ask your endocrinologist about it or your PCP. My mother took parathyroid hormone and was successful after 2 years, and she worked with an endocrinologist. Yeah, so bingo. I'm not an endocrinologist, right? So I'm an orthopedic surgeon advocating for bone health. But if I tell you something that directly about, some of these hormones and stuff that is different than what an endocrinologist told you, trust the endocrinologist, right? I'm an orthopedic surgeon. I want you to work with your endocrinologist. They're my colleagues. I'm not an endocrinologist. So, working with an endocrinologist to maximize your bone health is, if you have osteoporosis, is absolutely something I would recommend. That's what the medications are for. Um, and it's just, that's outside my scope of practice. So like, that's why I didn't talk a ton about the medications, because it's not my specialty. I mean, I focus more on the surgical side of things, I guess. Um, how significant is a genetic link? I think that's, um, a genetic link is important. I mean, the nature versus nurture type of debate from a pathology standpoint is one that is very interesting to me. In orthopedics, not just osteoporosis, but I think that in a lot of ways, and I talked about this during my last talk, a lot of ways people always, and I don't want you guys to hear this from me either, because I talked a lot about lifestyle. People tend to blame themselves for some of the pathology that they have, and I don't think you should. So, a lot of diseases, including osteoporosis and osteoarthritis, are really just built into your genes and your DNA. I used this during my last talk. I said, some people get gray hair in their 20s, some people get gray hair in their 70s, right? Nobody blames the person who gets gray hair in their 20s and says, wow, they really didn't take care of their hair. It's that's just how they were born. They got gray hair when they got gray hair. Meaning, don't blame yourself if you got osteoporosis. It very well could be that's just how you were born. You were destined to get it. It's not, I mean, again, it becomes philosophical at a certain point, but my point is don't blame yourself saying, oh, it's because I didn't take vitamin D, oh, it's because I ate unhealthy. Instead, realize it's multifactorial. There's a huge genetic component to it. And if you do have a genetic risk, it's probably more important to think about it and talk to your doctors about it and have specific strategies to minimize the effect of it. Um, I mean, knowing that you have that, genetics is valuable. Use that as a weapon, right? Use that in your favor. Oh, I know that I have a genetic link for osteoporosis. I have to be more aware of it. Prolia is one of the drugs that would be very good for osteoporosis. I believe that's one of the anabolic ones. Um, Strength exercises for seniors and women on YouTube. That's a good way to start. There are tons of videos for home exercises you can do at home. I agree. Um, and then it's try them out. To try one until you like one would be what I say. If you don't like the first one, try the second one. Find one you like. It's okay if you don't like one. Do something else. Calcium citrate plus magnesium, superior to other forms of calcium. If I do prescribe calcium, it's calcium citrate. But I don't necessarily have any data to support that it's better than anything else. What about infusions? That's the medications. So the infusions are the medications. So most of the medications, not all, but most of the medications are infusions. They can be, some of them are once a week, some of them are more frequent, some of them are less frequent. Again, not my necessary field of specialty, but those are the ones that they have side effects, but they have benefits. And if you have osteoporosis, um, that would be one to consider. Fosamax is different than Prolia. Fosamax is not anabolic. I know that. Anabolic meaning building bone, specifically building bone. Fosamax is not one. Fosamax stops bone breakdown, which isn't a bad thing. That doesn't mean Fosamax is bad. That's just what it does. So it is good for bone health because if you stop bone breakdown, it means your bones won't break down as fast. I mean, it's as simple as that. Is jumping good for bone health? Jumping, I don't jump that much anymore. Jumping if you like jumping, do it. if that's your if that's a way to, get you doing 30 to 40 minutes of activities and jumping is something that helps you do that weight bearing exercise, I think that's great. That can be your flavor of weight bearing exercises. If but it's not like only people who jump have good bone health. So you can do other exercises that are great for your bone health and avoid jumping. So um, it's a little bit of a hedge, but um, you don't have to jump by any means. That's me talking to the chat.
So if anyone wants to come off mute and ask a question, oh, I see another one in the chat.
So yeah, it says osteopenia. Would infusions be useful now or just for osteoporosis? Currently do weightlifting and weight bearing exercises. So that's a great question. If you haven't had a broken bone yet and you have osteopenia, you don't have an indication for the medications at this time, usually. Like I said, if you have it's such a very complex field and there's so many different causes. If you have other causes that can change the game a little bit, but given nothing else is going on, usually osteopenia alone is not an indication for the medications because the medications have bad side effects, unfortunately. These are not like if they didn't have side effects, I mean, it's glib to say, but sometimes I say, if medications didn't have side effects, we'd put them in the water, right? Like, I mean, we'd give them to everybody if they were only beneficial. They just aren't, right? So we have to be careful with these things. So that doesn't mean you shouldn't talk to your PCP about it. If you have osteopenia and you know it, get DEXA scans regularly. Sometimes it's yearly, sometimes it's every 2 to 5 years. Keep doing the exercises and focus on the diet. There's other things you can do, um, but you don't necessarily need the medications. You're not doing nothing. You're doing other things. You're doing the safe stuff. So don't think you're doing nothing if you're not taking the medications. You're doing something. You're taking the vitamin D. You're doing the weightlifting and weight bearing exercises. That is more than some people do. Like, right, you're getting ahead of the game. You're aware of it. Knowledge is power. Is it okay to lightly jog with osteopenia? Again, it is, provided you're being safe and you don't fall. I mean, yes, it is. Um, it, try to do what you like to do. If you like to jog, yeah, you should. That like I'd rather you jog and load those bones, and that'll help them, stay strong. Um, everything's a risk benefit in some ways, but I also wouldn't tell somebody who says, "Well, I hate to jog. Do I have to jog?" I say, "No, you don't. Find something else." Right? So um, it's the stuff that I'd be most worried about would be stuff that would put you at risk of falling or risk of putting yourself in a situation where you could eventually have a broken bone that wouldn't even be a fragility fracture, right? So, like somebody who falls while running isn't a fragility fracture. That's usually a higher energy injury. So, like that wouldn't fall under the class of fragility fractures. So, obviously, people fall while running and break their bones. So, like that doesn't mean you can't run. It becomes a discussion of if you enjoy it, if that's the way you stay healthy, the benefit probably outweighs the risk.
I have a question about age of, I think insurance covers a bone density scan at 65. I think that's
Mhm.
kind of the recommended age, which do you think that's maybe a little too old?
It's a tough question. I mean, from my standpoint, in my clinic, usually I will, if I'm seeing you for a fracture that I think is a fragility fracture, I'll be able to get it no matter your age. Um, from a preventative standpoint, that's so tough. I don't know enough about it. It's a great question. But I think that be better proposed to someone maybe in primary care or endocrinology. I would be behind it, right? I would support getting it, particularly for people who have risk factors like, oh, I got a genetic risk factor for it, or I had really bad asthma and was on steroids a lot when I was younger, or oh, a big risk factor is if you had a hysterectomy or ovaries removed when you were really young. That's a huge risk factor for osteoporosis, because female hormones, specifically estrogen, are so important for bone health. So if you had, uh, your estrogen sort of surgically removed, that's a huge risk factor for osteoporosis. So with those risk factors, I think getting earlier bone density studies makes a lot of sense to me, and I can propose an argument for it. But insurance companies do what they want to. So, like,
Oh, here's another one. Can you
yeah, I
turn?
like that question. I do think hormone replacement therapy is a really good option for women, specifically postmenopausal women, to help with bone density. So again, it's not something that I do in my clinic, but I have asked patients in my clinic, "Were you ever on hormone replacement therapy?" Or have you had, your ovaries removed? And if they were you on hormone replacement therapy? That's sort of my way of assessing their risk factors. And if they say no, I consider them higher risk for osteoporosis. So like, again, I'm sort of just playing my part, but like from that perspective, if you're saying, well, if you ask that question, you think they're higher risk, the logical sort of intuition would dictate that hormone replacement therapy is good for prevention of osteoporosis, and I would agree. Just, I guess my role for that with you is just to say, maybe talk to your primary care provider about it, talk to maybe your OB/GYN about it. which I mean, OBGYN is about as far from my specialty as you can get, but like it's important, and that relationship that women have with their OBGYN is super important. So talk to your OBGYN about that too.